Knee pain makes up about 1/3 of musculoskeletal problems seen in primary care settings. Knee pain is a significant source of disability and may restrict the ability to work or perform activities of daily living. A thorough history should include description of the location, character, inciting and alleviating factors. If the patient describes popping, locking, or catching, a meniscal or cartilage injury may be present. Knee stiffness and swelling may be signs of inflammatory arthritis. Gross deformity of the knee may be a sign of ligamentous injury or fracture. The knee bones include the femur, the tibia, the fibula, and the patella. The knee joint itself is rather unstable because of the way the bones articulate. The knee joint has several articulations, including the tibiofemoral articulation, a condylar joint with two convex condyles on the femur that fit into two shallow concave condyles on the tibia, the patellofemoral articulation, which is a gliding joint, and the proximal tibiofibular joint, an articulation between the lateral tibial condyle and the fibular head. Ligaments, tendons, a fibrous capsule, and surrounding muscles all help to stabilize the knee joint. The medial and lateral menisci allow knee rotation and act as shock absorbers. Stability is provided by the medial collateral ligament, the lateral collateral ligament, the anterior cruciate ligament, and the posterior cruciate ligament. Lastly, several bursae help to cushion the joints: the prepatellar bursa, the superficial infrapatellar bursa, the deep infrapatellar bursa, and the anserine bursa. Typically, these bursae are not palpable or painful unless they are inflamed. Inspect the knee for abnormalities with skin, bony structures, and muscles. Assess the knees for asymmetry, redness, scars, and malalignment. This is when you assess for varus or valgus deformities of the knee. Visually evaluate the quadriceps muscle bulk, as atrophy may indicate a long-standing knee injury. Next, palpate along the medial and lateral tibial plateaus and along the joint line, as well as along the medial and lateral femoral condyles. These bones are best palpated with the knee slightly flexed. Use your thumbs to palpate along the joint line and bony structures, while the rest of your fingers provide support underneath the knee. Using similar hand positioning, moving proximally to distally, palpate the quadriceps tendon, the patella, the patellar bursae, and the patellar tendon. Also, palpate the anserine bursa, which is found overlying the medial tibial tuberosity. Next, perform range of motion, first passively, then actively. Passively flex the knee. Often the posterior heel can touch the buttock. Up to 135 degrees of flexion is normal. Next, passively extend the knee. Normal knee extension is 5 to 10 degrees of hyperextension. Next, test stability of the medial and lateral cruciate ligaments. To test the medial cruciate ligament, place the knee in 30 degrees of flexion. Place stress at the lateral knee and look for joint opening and facial grimacing. Similarly, to evaluate the lateral cruciate ligament, again place the knee in 30 degrees of flexion. Place stress at the medial side of the knee. Look for joint opening and facial grimacing. To test anterior and posterior cruciate ligaments, the anterior and posterior drawer test may be performed. With the patient supine, the hip should be flexed 45 degrees and the knee should be flexed to 90 degrees with feet flat on the table. Using both hands, place thumbs at the level of the joint line just lateral to the patella. Attempt to move the tibia and the fibula forward and backward. Any laxity is abnormal. The knee joint should also be examined for inflammation and fluid collection. The knee should be cooler to touch than the adjacent thigh muscles. With the patient supine, the examiner should extend the knee and ensure that the quadriceps tendon is relaxed. The examiner should then perform an upward stroking motion on the medial side of the patella, pushing proximally from below the tibial plateau upwards towards the suprapatellar pouch. This motion should immediately follow with a stroking motion lateral side, superior to inferiorly. If fluid is present, a fluid wave or bulge may be observed on the medial side.